Good afternoon. I'm Kristen Flewitt, Program Manager at the Ohio Chapter of the American Academy of Pediatrics. On behalf of the Ohio AAP and the Ohio Department of Health, thank you for joining us for today's webinar, Owning It, Preparing Adolescents and Families for Transitioning to Adult Care. Before we begin, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded, and you are currently in a listen-only mode. Use the question box to submit any questions throughout the session. We will designate time at the end of the webinar to answer as many of your questions as time allows. A link to the audio recording of the entire webinar will be sent via email in the next week. During the webinar, 10 multiple-choice questions will be presented. We will use polling software to record your responses. Please be sure to answer all the questions, as this will serve as your quiz for MOC2 credit. If you've never used polling before, don't worry, it's really easy, and we will walk you through it when we get to the questions. Polling tends to work best if you are logged in on a computer. If you are accessing the webinar using a smartphone, polling may not work. No worries, you can submit your answers to the quiz questions by replying to the email you received with all of the webinar information. Also, if multiple colleagues are logged in together in one office, only the colleague whose email was used to log in will be able to do the polling questions, but again, you may simply respond to the email with all of the webinar information with your question answers to get credit for the quiz. Now, I'd like to welcome our two presenters today, Dr. James Fitzgibbon and Dr. David Banis. Dr. James Fitzgibbon received his medical degree from Wayne State University and completed his pediatric residency at Akron Children's Hospital. He is board certified in adolescent medicine. Following his residency, Dr. Fitzgibbon served in the United States Air Force as a pediatrician. Additionally, during that time, he also ran a school-based clinic. Dr. Fitzgibbon served as the Director of Adolescent Medicine at Akron Children's Hospital from 1980 to 2016. He has been a member of the American Academy of Pediatrics for almost 40 years. He is a member of the Society for Adolescent Health and Medicine and the Ohio Valley Chapter of the Society of Adolescent Health and Medicine. He has been a member of the Sports Youth Committee, currently known as the Adolescent Committee, for the Ohio Chapter of the American Academy of Pediatrics since 1980 and served as co-chair of that committee from 1999 through 2005. He is also a member of the North American Society of Pediatric and Adolescent Gynecology from 1987 to present and served as a board member from 1995 through 1997. Dr. Fitzgibbon has been blessed to spend a significant amount of his time providing direct clinical care for children and adolescents, in addition to providing training to future physicians at Akron Children's Hospital. Also joining us today as a presenter is Dr. David Banis. He is Associate Program Director and Medical Director of the Mount Carmel Family Medicine Residency Program in Westerville, Ohio. He is board certified in family medicine and has a certificate of added qualifications in adolescent medicine. He received his medical degree from the Ohio State University, completed a residency in family medicine at the Cleveland Clinic Fairview Hospital Family Medicine Residency Program, and a fellowship in adolescent medicine at the Metro Health Medical Center. Dr. Banis has a special interest in eating disorders. And with that, I will turn it over to Dr. Fitzgibbon to get us started today.
Thank you very much for joining us in the last of our three webinars. You may hear a little bit of repetition from the previous ones because I think learning about how to communicate with teenagers, learning how to engage in their health care, and now learning how to add competency and transition are very related and a continuous theme that we hope we can accomplish. Our objectives were to take a quick look at adolescent development, to look at the role rapid development plays in both the prevention and development of future health issues, to emphasize the central role for confidentiality in adolescent health care, and also to look at some of the special care needs for transition in adolescents with those needs. Next slide. At the very least, we hope at the end of this we will be able to let you know that transition is more than just an appointment, and we will do better. Thank you. Next. When we think about adolescents, I think their rapid growth is important. The author of the Zits cartoon strip has long been my sort of muse for adolescent healthcare. In this one, we talk about what's your problem seeing your pediatrician, Jeremy? Are you kidding? I'm 15 years old. In a year, I'll have a driver's license. In 3 years, I'll be able to vote. I'm a little beyond that on the maturity scale. And in the next room, hey, Power Rangers. Next slide. I think what we see with adolescence is a period of rapid growth, perhaps more so than any time outside the newborn period. During that time, we often have to look at risky behaviors because they create a significant morbidity and mortality during this time. And how to access care, we do have to look at the changes in adolescent development, and as we had spoken with in earlier webinars, how to address the needs and get the kids to come in are very important, and then the central role for confidentiality during this time of rapid growth. Next slide, please. One other issue that we hope you to leave with is that behavior really is a complicated endpoint of the interaction of the environment, experience, education, brain growth, families, and experience for these teenagers. So any solution to move behavior in a different direction is much more complicated than just talking about T-shirts and hats. Next. We've arbitrarily divided the development into early, middle, and late. Next. During this time, I think perhaps one of our first hurdles to overcome is, since this is a rapid time for adolescents to cognitively grow, we have to be willing to look at a behavior that an adolescent may be engaging in and understand that that adolescent observed whatever was going on in his life or her life and made a judgment about a need and then developed a behavior to what they felt was meeting that need. So we have to avoid the I don't understand part of this cartoon and listen to their needs and search for the need that they develop the behavior for, even if the behavior is inappropriate, because if we don't address the need, we're not going to change the behavior. And that's what being half Dogbert is. We don't have to be a full-blown adolescent, but we at least have to give them the credit that their behavior might have come from what they view as a needs assessment. Next. When we talk about this early, middle, and late development for teenagers, I think in the early adolescent, that 11 to 13 or 14-year-old, cognitive development is exploding. Books are written about magical thinking, the ability to hypothesize, and lots of things happen when you get that feeling of specialness that happens when your cognitive growth improves. This is often layered with perhaps some of the most rapid physical growth during that period of time, except for the newborn time. And so that the interaction of that cognitive specialness and the gaining of all this new physical ability and physical growth really often produces different development of different behaviors that we have to think about and recognize that brain growth is just now starting, and with all of our new science of the new neuroscience that looks at the continued brain growth into the second decade, this really is very exciting times for these early teenagers. Middle adolescents, those 14 to 17, 18-year-olds, those kids are much more independent. They drive, they date, they work, they go to school. They are forming some of their relationship issues, their ability to interact with people, their ability to look perhaps at education or at the world of work and where they want to go. And sometimes it involves taking more risks. This is where most of us spend most of our time with teenagers, in this middle group, trying to work with them and help them navigate some of the things that are going on. Again, brain growth is still going on. We worry about things that impact brains at this time, and so we need to think about that as we're addressing teenagers during this rapid growth of development. Late adolescents, these 18 to 21 to 25-year-olds, perhaps those emerging adults, as some people like to call them, they can become a lot more goal-oriented. College, work, Perhaps their relationships move towards more intimacy, more self-determination, and this includes their health care. They should at this point feel engaged enough with us that they can ask or look for more health care in a way that what they want to change if they have questions. So this is sort of the end point, and one of those skills they should have when they reach this late adolescence is the ability to understand why transitioning to the adult world is important and have some skills to do that. Next slide, please. The other thing that happens in this behavioral time is to look at that biopsychosocial engagement that happens with adolescents. It's not just that they got older. It's not just that their brain growth increased. They also have families. They grew up in a culture. They grew up in an environment. They grew up in a school. And so all of those things that we're looking at are also impacted by all of those things. So their cultural background, their genetics, their imposing things that happen in their life at school, the increase in trauma that they see, the experiences they have, layered on top of their brain growth and their ability to perceive what's going on around them really does contribute to how they make decisions. This is an old slide I found, obviously, if you noticed, 1993. Some of you were around then, I hope. If I were practicing in 1593, I'm thinking I'm pretty good. I might be able to just have abstinence in my back pocket and move contraception in a little later. But I don't practice in 1593. Even in 1993, when fertility started at 11 and marriage was at 22, and that fertility isn't much different, but I think marriage is a little bit older now for most of our kids. I might have a little more need for talking to them about how to approach the development issues around sexuality. So keep in mind that also how they interact with us in the field of medicine also relates to that biopsychosocial input. Do the family use doctors? Do the family go to counseling? Those things are important. Next slide, please. So the key concepts to take away from that concept is the initiation and progress of development through cognitive, physical, and psychosocial domains. While each of those may be parallel, they don't all start and stop at the same time. The interaction that occurs because of that on physical development actually might affect the behaviors we see. For example, an early blooming male may get lots of positive feedback in the area of sports, which may give them some self-confidence, but at the same time may not give them any resiliency. They've always done well. They always get lots of strokes and support for their sports abilities because they're just bigger than everybody else and they have some natural talent. So that concept of the mismatch between their physical and cognitive development might create some behaviors. And then that final concept that this rapid period of growth and development really creates vulnerability and resiliency. The vulnerability is the earlier you engage in risky behaviors, the more likely you are to have a bad outcome. So the concept of delaying first risk, so having your first drink at 18 instead of 14 might make a difference in the risk you have for developing problems with substances. Delaying first intercourse till 18 or later might impact on whether or not you use a condom. So those are things that directly flow from this interaction of cognitive and physical development and their interaction with the environment. Next. I apologize to the psychologists in the group that might be listening, but this is Erickson, and Erickson talks about cognitive development as a gaining of competencies starting from infancy and moving into adulthood. I think this is true for adolescents. Next slide. Again, this is Erickson's slide, but if you think about when we often see teenagers, they often come in because there's a breakdown of something. Either they're having trouble with substance abuse, they're not doing well in school, they got kicked out for a fight, they got picked up for speeding. Those kinds of things may cause some sort of interruption of this nice forward progressing gain of competencies. So when we want to end up with a nice pyramid, one of the things that we sometimes forget to do is we have to go back and reconstruct when did they really fall off the pyramid. Did they fall off at 7 when mom and dad had a divorce and now we're just kind of have to rebuild that? Or is it just that they got in a wrong crowd and just had substance abuse now? The other concept of building this pyramid and to getting to adulthood is the competency of being able to have skills to transition healthcare. And we'll get to when that starts and why it really needs to start at the beginning of adolescence at 11 or 12 as how we need to do that. But think of that rapid period of growth and that building of the pyramid and trying to get to adulthood with all of those skills that are needed and our role in helping adolescents navigate and also recognizing when we have to sort of backfill areas that needed fixing so that those competencies are there so they can move forward. Next slide. Again, referring to my muse. Mrs. Duncan, would you step out of the room while I ask Jeremy some questions? Oh, okay. No problem. I mean, absolutely. Doctor-patient confidentiality. Click. Is she listening at the door? What do you think? I am not. Again, trying to focus again on confidentiality and moving it into your workflow so that the family knows that it's part of it and that can move forward with time alone. Next slide, please. As you recall from previous webinars, we have spoke about making confidentiality a key component for accessing healthcare by teens. And again, the concept of some time alone with the doctor, it's a key element to improving healthcare for teens. And I would maybe take one step forward and say that time alone allows practice in how a teenager, especially a younger teenager, might practice talking about their health care, advocating for their health care, and gaining some skills on how they might turn those into transition skills and how to access care better when they're on their own as an adult. So the office should reflect that culture of confidentiality, and it should start at the front desk and be woven throughout the office flow. Next slide, please. We've mentioned health risks that might be initiated during adolescence. Some of the ones that are really common, 31% initiated smoking before 16, 86% of teens consumed alcohol by 21, but often recall drinking between 15 and 17. 75% of emerging adults with psychiatric disease had at least one episode before 18. These are things that we need to be aware of because teenagers need to recognize these as a health issue and need to recognize that this is part of that special needs things that we need to help them transition to the adult world with. Next, please. Again, finishing a little bit more on the time alone, face-to-face discussion with providers helps teens engage in their health care and mature autonomy as well as receive some needed guidance in sensitive topics. Learning how to pick up a prescription, learning how to make a phone call when they have a question are all skills that they will need later. Only about 40% of 12 to 17-year-olds spend time alone with their providers. This is from Paving the Road to Good Health, which we, I think, provided earlier as a supplemental reading if you want to look at that. This is a very excellent, well put together document on how to approach adolescent health care. And finally, the confidentiality of care fosters that increased engagement by teens in their own health care. And I think those are things that will pay off in the long run and finish that pyramid that we saw about gaining competencies. Next, please. Now, as we think further about how that healthcare transition might occur and what we want to see, we would really see that adherence to care occurs. We would like patients to be able to report health and quality of life. We would like skills around disease knowledge, self-management, and readiness to transition and carrying out that information. They need to be satisfied with what goes on in the office so we can transfer care and help them transfer care. And some realistic things, we have to make it cheaper, we have to make it better, and we have to improve the quality. Next slide. Thinking of it in our developmental mode, I think by age 12, when we start that time alone with the physician, that's when we try and use as one of our goals with the family is this is a time for the kids to gain some control of their health care, to be able to advocate by themselves and allow them to some privacy to have that growth. And then as we ramp up that time at 14, we need to start moving a little bit more transition because they're doing more independent activity. Between then and 16, they're doing lots more activities, other places independent, and that's what we now begin our preparation of youth as they approach care on their own, encourage them to make their own phone calls, encourage parents to teach them how to pick up their own prescriptions, and move forward in a way that we need to do that. And then between 18 and 22, we need to formalize that transition to adult care, and particularly perhaps starting as early as 14 to 16 if there are special health care needs. Next slide, please. In terms of actual numbers, in the U.S., every year about 4.5 million 18-year-olds come upon the United States. About 25% of those have special care needs. So then every year, about 1 million special care needs kids need to transition somewhere in the next couple years. When you look at older young adults, that emerging adult, that 18 to 25-year-old, they have worse health care than younger kids and worse health care than older kids. Their health is worse. They use the ER more, and they tend to be more dissatisfied with health care in general. Our need then is, with that diminished health and compromised quality of care, we need to make some improvements. So that's where we come up with the transition, particularly for that 12 to 17-year-old with special health care needs. Next slide, please. So those patient goals are to improve the ability of youth and young adults to manage their own health care, to ensure some organized clinical process, and to recognize that transition doesn't equal transfer, and that transition is an explicit process. Next, please. So did you and Dr. Gale have a nice chat? I guess so. She wanted to know if there's anything you should know about my personal life. And what did you tell her? I told her the truth. With you for a mother, I have no personal life. Next slide, please. So as this emerging adult gains the achievement of responsibility and gains the ability to recognize their own needs and how to fulfill those needs, and at the same time not depriving others of their needs. That's a little philosophical, but I think that's the adult we would like to see in transition. Next, please. We have lots of barriers that we will continue to talk about, particularly in the lack of coordination and smoothness between pediatric care and adult care. Next, please. Everybody has really got this urge to hurry up and get transition done. It's a lot harder, and we really have a lot of barriers we have to overcome. Next slide. Perhaps if we can at least get to this stage in our transition, we'll do a little better. And my final slide, I think. Next is questions. All right. So we'll start with some questions. Currently, only about 40% of 12 to 17-year-olds spend time alone with providers, making counseling around risky behavior difficult. True or false? Please submit. And the answer is true. While we're doing better, we still have some ways to go as far as that. Next question. Young adults, 18 to 25-year-olds, overall have worse health than younger and older groups and use ER much more often for their health care. True or false? And the answer is true, and that's really our major goal in improving our transition. Next. Which of the following are true about confidential care? A, confidential care is a key component to health care for teens. B, time alone with providers is essential for improving adolescent health care. C, office culture must reflect confidential care for success. D, all of the above. Yes, we need all of those to really do better with our health care. Next. Teens with special needs account for about 1 million teens needing transition each year. True or false? Yes, that's true, and these are probably our most challenging kids in some cases. Next question. Adolescence, which of the following parts? Adolescence is a period of rapid growth and development. B, risky behaviors during adolescence result in significant morbidity and mortality. C, access to care needs to reflect developmental needs and stages. D, confidentiality is a key component to quality of care. E, all of the above. Yeah, it's really all of the above for all of these. And again, thank you very much for your attention during my section. And I believe Dr. Banas is going to take over.
Hi, everyone. Thanks for joining us, and thanks for the invitation to talk about transition of care. Next slide. So the objectives for my component will be to describe why transition of care impacts the health of patients, list the benefits of an effective transition, implement tools to facilitate patient transition, and identify the 6 steps of transition described by gottransition.org. So transition is a really hot topic today. It's discussed pretty much at every Society of Adolescent Health and Medicine meeting that I've been to in the last few years. Next slide. So Dr. Fitzgibbon kind of touched on this. Transfer refers to the end of care by a pediatrician and the beginning of care with an adult provider. It's sort of a discrete period in time versus transition, which is a process. So it's a process of purposeful planned movement of teens with chronic medical conditions from child to adult-centered health care. So I would encourage everybody to look at transition as a process, as Dr. Fitzgibbon mentioned, over a period of several years and not just that discrete period of time where patients move from pediatric to adult care. As opposed to transfer, transition is complicated. It's multidisciplinary, and it has a beginning, middle, and end. And in order for transition to be effective, it requires providing support structures for patients to continue their health care with adult providers. Next slide, please. So Dr. Fitzgibbon touched on this briefly. There's about 4.5 million patients aged 12 to 18 requiring special medical needs in the United States. 90% of children with chronic disease survive to adulthood and require transition. And as an example of this, if you look at the percentage of patients with cystic fibrosis reaching age 18, this has increased from 27 to 56% from 1982 to 2007. And the number is expected to even get bigger yet, to up to 75% by 2025. Therefore, this need for a more formalized transition of care is becoming more and more important. It was first identified in the early 1980s, but as I mentioned earlier, it's becoming more and more of a hot topic. Next slide. So it's important to remember that transition involves both physical, psychological, and social changes for patients. And if we don't address each of those components as providers, patients can fall into this quote-unquote care gap where they don't have an effective transition and they may not even have health care at all. So our goal should be to avoid that care gap and to bridge that gap by providing appropriate transition of care. Studies have shown that transition is often associated with a decline in the health of patients with chronic conditions, and again, our role as providers is to mitigate that. Next slide, please. Transition does require cooperation of patients, parents, adult providers, and the pediatric provider. I'll get into that in a little bit more detail later. There are several benefits for a well-planned transition. Patients are more satisfied with their care. They're better able to take care and manage their own health care, and they feel empowered regarding their health care as well. Benefits of continuity of care associated with transition include a decreased number of hospital admissions and ER visits, like Dr. Fitzgibbon mentioned earlier, and a greater use of preventive health care services. Next slide, please. The flip side of this is poor transition of care negatively impacts disease outcomes, health education, and chances of a successful adulthood. So some more specific consequences of poor transitions includes inappropriate healthcare utilization, again, such as the ER visits and hospital stays, treatment non-adherence, and failure to establish connection with an adult provider, and lastly, a low frequency of medical visits, which obviously will contribute to that poor quality of care as well. Next slide, please. So here's some conditions that have commonly been associated with transition concerns. This is by no means an exhaustive list, but things like congenital heart disease, cystic fibrosis, as we've already mentioned, diabetes, cancer. I know as an adult care provider, that's one that I often worry about in terms of transition of care because I'm less familiar with some of the more mundane pediatric cancers, HIV, Ehlers-Danlos, and I personally receive a lot of transition of care of mental health issues, and obviously depression, eating disorders, ADHD, MRDD, and autism all present transition of care challenges. And LGBTQ care also can present a transition of care concern as well, particularly if you have teen patients who are identifying as transgendered, and it's often difficult to find adult healthcare providers who are comfortable with that issue. Next slide, please. So many providers struggle with transition of care both from the pediatric and the adult end of the spectrum, especially surrounding when and how to transition that care. There's often patient anxiety and parental and provider anxiety as well surrounding this transition, and it's up to us as providers to alleviate that anxiety through appropriate preparation, and as I mentioned earlier, that needs to start earlier rather than later, and again, to treat transition as a process and not a discrete period in time. Next slide, please. So characteristics associated with transition readiness. So studies have shown that teens who are older transition better than teens that are younger. Teens that have less severe disease or less severe chronic medical conditions also will transition more easily. I think this is probably intuitive. Attendance of a transition clinic, such as the one at Cincinnati Children's and in other places as well, that also is associated with improved outcomes for transition and associated with transition readiness. Lower anxiety associated with the transition, again, both with the patients, parents, and providers, and a higher confidence in adult care providers. And one brief word about that is I think it's a good idea for pediatricians to develop relationships with adult providers in their area so they know who are, the adult providers that are comfortable handling specific chronic medical conditions, and developing a relationship with those providers can really improve transition of care. And I know in my area, I get a lot of mental health issues that are transitioned from pediatricians in my area because they know that I'm comfortable handling those issues. Next slide, please. So barriers to transition. There's a bunch of them. One would be inadequate preparation, as I kind of hinted at before. Along these lines, lack of referral to a specific adult care provider. I think patients are really looking for their doc or their provider to give a specific person or individuals names that they are familiar with, and not just say it's time for you to move on to an adult care provider. Poor communication between providers, and I'll get into that in a little bit more detail later. Lack of structured and detailed plans for transition of care. Under the second big heading there, ability to access and utilize health care. So there's limited availability. I know in my area, particularly primary care, there's patients and not enough providers in our area, so there may be limited availability, and patients may go on waiting lists before they're able to be seen. And particularly with patients who have those chronic medical conditions that may be more complicated, that makes things even harder yet. Limited clinician time, I think that's probably an issue with just about everybody, adult and pediatric providers as well. We're always being asked to do more in less time. And waiting lists I kind of already mentioned. Next slide. Other barriers, complex health conditions, as I hinted at earlier. It's difficult leaving a familiar place if you're a patient. If you have inadequate self-management skills, that makes things even more difficult. And as Dr. Fitzgibbon mentioned, it's important for us to start cultivating those skills earlier rather than later. And a history of non-adherence with meds or other treatment follow-up also contributes to barriers as well. If there's parental over-involvement or over-enmeshment in patient care, that can be a barrier. Abrupt or unplanned transitions can be a barrier for good quality of care. And if pediatricians are unable to surrender care, such as with lack of trust in adult care providers by either parents, patients, or pediatricians, all of these things can negatively impact transition of care. Next slide, please. Other barriers, difficulties with records transfer. I think this is becoming easier with electronic health records, particularly things like Epic's Care Everywhere, but it's still an issue. I still personally experience problems with this as well. Difficulty coordinating care between specialists. Again, a lot of patients that are in need of transition, they're seeing one or more subspecialists and kind of getting everyone together and on the same page during that transition process. It's hard enough prior to transition, but then in the transition process, that makes things even more acute. Difficulty for providers to see patients independent of parents, as Dr. Fitzgibbon hinted at earlier. Lack of training of healthcare providers, either in transition or in the specific chronic conditions they're being asked to manage. Lack of flexibility of services, and failure to include the patient in the transition. Again, all of these are barriers to transition. Next slide, please. So I wanted to speak briefly specifically about mental health transition, which I think presents some additional unique problems. And as I mentioned before, I do a lot of mental health transition myself. There's several studies that have shown there's a significant decline in use of health care by patients with mental health issues as they transition to adult care. So more than other chronic medical problems, patients with mental health issues are at much higher risk for falling in that care gap. Mental health issues commonly present in or become more serious during adolescence, and transition for patients with mental health issues is more complicated than for patients with other medical issues. Next slide, please. So some additional obstacles to mental health transition that exist above and beyond the usual transition of care that we're dealing with is patients may be ambivalent about their recovery, and that certainly makes things much more complicated. Effects of patients' mental illness on their development. So they may be delayed developmentally, cognitively because of their mental illness, and that certainly will make transition more difficult. And there may be decreased parental involvement during and after the transition of care and mental health issues for various reasons, and that can certainly also complicate the transition of care as well. Next slide, please. Components of a successful mental health transition according to the TRACK study: at least one meeting with an adult provider and the patient prior to transition of care, continuity with mental health care workers before, during, and after transition. We'll get into this in a little bit more detail in a couple minutes. Communication between providers and services, and I think that's true across the board in transition. And flexibility of transition age between patients, because we all know developmentally, cognitively, patients may be the same chronologic age, but are different in terms of their development. Next slide, please. Possible transition components. So education and training initiatives for patients, families, or providers, and I would probably also add to that staff in the office as well. Structural changes in the office, such as improving information transfer. I'll get into that also in a couple minutes. Developing transition clinics, again, like Cincinnati Children's has done. Enhancing professional roles, such as using a nurse or a social worker to work with patients and coordinate transition. We're fortunate in my office to have 3 social workers who are involved in this role, and they can really be invaluable. Next slide, please. In terms of healthcare transitions, the AAP and the ACP recommend practices select a readiness assessment tool that can be modified for specific patient situations. Transition readiness refers to this empowering of patients and those involved in their care to prepare for, enter, and complete the transition. And assessment of readiness transition is not performed in a consistent and uniform fashion all the time, and that's one of the things that I think we probably could do a better job across the board is assessing that transition readiness. Next slide, please. So I'm not going to get into specifics about tools, but I wanted to give you some examples of tools. There's two categories of tools. One would be disease-specific tools, and then the non-disease-specific tools. So there are several tools out there to assess transition readiness for specific conditions, such as for cystic fibrosis and for HIV, as you can see on this slide. Next slide, please. And here we have a couple examples for renal transplants and liver transplants and sickle cell disease as well. Many of these are easily accessible on the web and can be free. Next slide, please. And then we have the disease-neutral tools. So these are transition tools that are not targeting any specific chronic medical illness or psychiatric illness, and they're just meant for general transition tools such as the Self-Management Skills Assessment, the TRACK, and the California HRTW Transition Assessment Tool. Next slide, I think we have the UNC transition tool on the next slide. And I've listed on here what the specific things each of these tools is kind of looking at and is targeting in the questions that are used to assess transition readiness. Next slide, please. So as I'm beginning to wrap up here, the 6 core elements of transition, this is found on gottransition.org, which is a really wonderful website, and it's also endorsed by the AAP Transition Echo, and you can find more information on the 6 core elements at both of those sites. I don't have enough time to go into extreme detail on each of the elements, but know that this is easily accessible at both of those websites, and you can learn more. One of the things that I found very useful about gottransition.org is it's not just targeting pediatricians who are transferring care to adult providers. There's also components that involve adult providers who are receiving patients from pediatricians as transition of care. And then there's a component for family physicians and med-peds providers who are basically keeping patients in their own practice, and how do I adapt my style of care as my patients age and become more developmentally advanced. So I think that there's something on this site for everybody, regardless of where you are in terms of how you're transitioning patients. So in terms of the 6 core elements, and Dr. Fitzgibbon mentioned this briefly in his component as well, the first component, which generally is starting around age 12 or 13, is to develop a transition policy for your office. And that involves educating staff about how are we going to transition patients. And I think it's important to utilize all of the members of our staff, nurses, MAs, front office staff, if we have social workers in our office, and using their skills in this process. Also, it's important early on to address how are we going to handle consent issues, because we're going to reach a point in the transition where we are going to need to be releasing records to another provider and speaking to another provider. And where in this process do we want consent and assent to happen, and how are we going to formalize that? In my practice, when I'm receiving patients as transition of care from another provider, my nurses basically know they already have forms filled out. I'm going to need to get records and consent to speak with specific providers, both who I'm receiving a patient from and if there's other providers involved in the patient's care. And so they know as soon as a patient arrives in the office on that day, they're having the patient fill out consent paperwork, and if it's a minor patient, the parent, and getting the patient's assent. The second component in the core elements is occurring around age 14 to 15, and this is transition tracking and monitoring. And I think this is a good idea. I admit I have not yet done this in an electronic record fashion, but I'm sure that these sorts of things are easily buildable. having a registry or a flow sheet to track your progress. And that registry can be a list of a bunch of patients in your practice and tracking where they are in the transition process, or it can be specific to an individual patient and keeping notes about where patients are in the tracking process so that when you pull them up at their next visit, you see where they are and what you need to do at specific visits. That can be a big time saver. The third component, which is occurring around age 16 to 17, is that transition readiness, as I hinted at before. Number one would be implementing a readiness assessment tool if you think it's appropriate. And again, all patients are different. So you might get a 16-year-old who is approaching readiness to transition, but you might have a 20-year-old in your office who's not. So I think using your clinical judgment as to when patients are appropriate for transition is important. And the other component of this is assessing patients' goals. What are their health goals, their life goals, their goals in a new provider? What are they looking for in a new provider? And how can we help them identify those things and find those things in a new provider and help them transition? Next slide, please. The fourth component here in the 6 core elements is transition planning. So this is generally happening, again, roughly age 17, 18. We want to update the plan of care for the patient. So, for example, if we have a diabetic patient, making sure that their med regimen is correct, what subspecialists are they seeing, who else is involved in their care, making sure that our plan of care is appropriately documented so that when we transition the patient onto an adult provider, everything is right there, and the patient will receive better care, and it'll be easier for the adult provider to pick up where you're leaving off. At this stage, we're also beginning to educate patients regarding the adult care model and how it's different from a pediatric model. There's a lot of good information on this at the gottransition.org website. And talking about things like independence, and your parents aren't always going to be there to help you along this process. How do you advocate for yourself within the healthcare system? And those consent issues also that I mentioned before. Discussing transition timing with patients, addressing any legal issues related to intellectual disabilities and having that documented so that information gets sent on to adult providers, making those specific referrals to discrete adult providers at this point, and if we haven't already done so, getting consent to release information and to speak to those providers. Next slide, please. And then at the nearing the end of the core elements here is the actual transfer of care. So we want to confirm a date of the first appointment with adult care and reaffirm responsibility that you're going to take responsibility for the patient until then. Ensuring stability of chronic conditions. We want to make sure the patient is as stable as possible before we transfer them. It's not a bad idea to write a letter, almost like a consult note, to the adult provider as a summary of what's going on with the patient. Are there specific issues related to the patient or the family that would be helpful for that adult provider to be aware of? And gottransition.org endorses this idea of a transition packet. So assembling a packet which would have that transition readiness assessment, what the plan of care is for the patient, including any pending items, goals of care that you and the patient have agreed upon, what an emergency care plan is, and any legal documents that are relevant to the patient's care. And again, making sure you have the consent from the patient to release this information as well before you actually release it. Next slide, please. And then after transition, I think it's important, and gottransition.org endorses following up in 3 to 6 months with the patient and with the provider to make sure everything went according to plan. Is there anything else I can do to help? Following up with the adult provider, is there anything else I can do to help my former patient? And as I mentioned before, these kinds of connections with the providers, with the adult providers, helps build relationships so that the pediatricians can identify who are the good adult providers to refer to, and so that those adult providers know that you care and are willing and ready to accept patients that require transition again in the future. Next slide, please. And as I mentioned, for more information, you can either visit that gottransition.org website, and there's tons of information also in the AAP Transition Echo as well. So again, I only had enough time to briefly touch on each of the 6 core elements, but there's more than enough information on both of these sites if you would like to learn more. Next slide, please.
So before we go to the next slide, which is the next quiz question, we did have a question chatted in I thought we could address. And that question is, what is suggested for transition of patients heading to college? Do we continue to see in pediatrics?
That's a great question, and I've encountered that being done in several different fashions. Many college-age patients are receiving care in student health centers, and we could certainly apply the same model that I talked about in transitioning to that student health center. I personally have experienced, and I know others have experienced as well, that the primary care provider will still maintain a relationship with the patient during the college years. In fact, I saw a patient in that situation this morning, but the patient would get more acute care at the student health center. So in terms of the pediatrician, I think it depends on how comfortable they are continuing to care for that patient up to a specific age. I know a lot of people go by age 21, sometimes it's even 18. So several things could be done there. The college health clinic could be the source of the transition, and then after the student leaves college health, then transitioning onto an adult provider. Or like what I referenced before, the pediatrician or the primary care provider can continue having contact with that patient while they're also receiving some of their health care in student health. Or if the provider is not comfortable continuing to care for the patient for whatever reason while they're in college, then maybe that's also the time to initiate that transfer of care to an adult provider and have the adult provider be ready to assume complete care of the patient when they've graduated from college. I hope I answered that question.
Great. Thank you, Dr. Banas. And so here is quiz question number 6.
So question 6, which of the following is not a benefit of an effective transition? I did a not question, even though I know you're not supposed to do not questions frequently. So patients being empowered to own their own care, improved patient satisfaction with care, low frequency of medical visits, and decreased hospitalization or ER visit rates. So the answer is C. So I'm not implying that we want a high frequency of medical visit rates, but an appropriate level of visit rates to whatever chronic condition is being established there. So we don't want patients seen at a low frequency where they might fall into that care gap and be at higher risk for ER visits or hospitalizations. So next question. Question 7, which of the following is not associated with readiness to transition? So A, management by a transition clinic, B, comfort with the current medical office, C, older age, and D, lower anxiety. So the answer here is B. So patients who are too comfortable with their current medical office are going to be more complacent and be less likely to want to transition. And as I mentioned earlier in the talk, management by transition clinics being older and having lower anxiety about transition are all associated with a positive transition process and readiness to transition. Next question. Question 8, why is it more difficult for patients with mental health issues to transition effectively? A, parents tend to be over-involved in transition. B, patients tend to overutilize healthcare services. C, mental health issues tend to present after the transition of care. Or D, patients are higher risk for not caring about their recovery. And the answer is D. Patients who have mental illness are more likely to be ambivalent about their recovery. And if you look at the other answers, patients who have mental health issues, the parents tend to be under-involved in their care, and they tend to underutilize healthcare services. And many, if not most, of these issues tend to present in adolescence as well. Next question. Which of the following is a condition commonly associated with transition concerns? A, upper respiratory tract infection, B, sexually transmitted infection, C, diabetes, or D, gastroesophageal reflux? And the answer is diabetes. Again, we're looking at chronic medical illnesses as being the transition concerns, not acute illnesses or less serious illnesses. And I know personally diabetes, I'm very comfortable managing diabetes, but teen diabetes tends to be a little bit more difficult. And as an adult provider, I probably would be less comfortable with that than taking care of an adult patient with diabetes. So in this question, diabetes would be the answer. And number 10, last question. Which of the following does not occur during the transition of care phase of the gottransition.org 6 core elements? So A, confirm appointment date with a new provider. B, write a letter to the adult provider. C, educate the patient and family on the adult care model. Or D, assemble the transfer packet. And the answer is C, educate the patient, family, and adult care model, which we hopefully would have done prior to the actual transfer of care stage. So I think that's the last slide. Summary: further research is definitely needed in transition of care. Again, it's a hot topic. It's important for us as providers to remember this is stressful for a lot of people, ourselves included. It's important to start early. Remember, it's a process, not an event. Transition of care is also a team event, not an individual event. Developing relationships is important both with your patient, your staff, and the providers that you're referring to. Consider use of readiness assessment tools and use the 6 core elements. So thank you for joining today, and again, thank you for the invitation to talk.
Great, and we have only had one question chatted in, so we have like 3 minutes left. This would be your opportunity if you do have additional questions to chat those in. Just to also mention, probably in the next week, you'll receive the slides from today's webinar and also a link to the recording should you want to forward that along to colleagues. And you can always follow up with me, Kristen Fluitt. That's who you would have gotten the email from for the webinar today. If you have additional questions about adolescent health or our resources and programs. So we'd like to thank you all very much again on behalf of the Ohio AAP and the funder for this project, the Ohio Department of Health. We do have one quick question that came up mentioning any billing codes, and I'm assuming that's meaning for services that are provided around transition. Dr. Fitzgibbon or Dr. Banas, could you address that before we end?
So I can mention that briefly, and I'm sorry I don't remember off the top of my head what the code is, but there is a code that you can use for transition of care, and it is on the gottransition.org site. I have seen it there, and I apologize, I don't remember what the code actually is, but there is a code that you can use for that purpose.
Yeah, and this is Dr. Dritz. Sorry, I'm going to throw in there. So just like Dr. Banas mentioned, the gottransition.org has a whole, like 1 or 2 pagers on tips on coding around transition to help maximize reimbursement. What also is involved in that coding that will help from a reimbursement standpoint in your clinic is coding for the screening tool if you end up using that as well. And I believe that's, again, actually the same code that you may be already using for your PHQ-9s or so forth. I don't remember the code off the top of my head. But that gottransition.org website that Dr. Banas mentioned addresses that very specifically. Though I have to say I think most clinics still struggle with actually meeting sort of the time that's often put into the transition versus the reimbursement that truly ends up happening at the end of the day.
Great. Well, we are at our 1:15 mark, so we will say goodbye. And again, thank you very much for joining.